Good morning and welcome, everybody. This is our Christmas special. We're doing a little bit of a talk, I think, on Spina Bifida. We got Dr. Lisa Apfel this morning, and she is with the newly found Department of Neurosurgery within Carilion. Yay! She's been here since 2007, 2006. Thanks for correcting on that one. Which, as I was thinking and reminiscing over patients that we've shared, she's been a fabulous surgical representative within our system for us here at the pediatric world. She's associate professor here at Virginia Tech Carilion School of Medicine along with VCOM. She did her training, undergraduate was at Boston University, and then up to Sunny and Buffalo, and did her surgical training there as well. And we kind of convinced her that she didn't like lake effect snow and wanted some warmer weather, so she's been down here since completing her neurosurgery residence there. Been instrumental in many things here, the neurosurgery residency, which we have up and running, as well as a lot of collaboration within the NICU, working on IVHs and things like that. And with that, Dr. Apfel, tell us about Spina Bifida.
Thank you. All right, good morning. Okay, for the folks that are viewing this via the tele system, I'm just wondering if they have questions, can we hear them or no?
We can hear them, and then Megan will watch the chat.
Okay, so because normally in person I would just say if you have any questions as we go, let me know as we go. So if there's a way to do that, just let me know, Megan. Okay.
Give your hand raise if there's something that comes up.
Yeah, okay, all right. It's clear to me, but it may not be clear to you. So good morning. So I wanted to review Spina Bifida and some of the considerations around it. Okay, so basic outline, so you don't think I'm going to talk about embryology for 45 minutes. I promise you that would never happen. So I wanted to do just a brief review of the development of the central nervous system, because then we can see how things unfold. If something goes wrong in X, Y happens, and there are so many different things that happen in development, and with a slight difference in a problem with a certain developmental stage, one little difference versus another little difference, you can have a completely different clinical entity and a completely different problem treated completely differently. And one might be clinically silent, and the other one could be very, very harmful to the patient. Okay, so embryology, I'm going to go over some different types, show you lots of pictures, examples, so you can really, so I can explain it a little better and you can see what I'm talking about. And then some of the signs and symptoms the Spina Bifida patient would have, and some of the associations with it, and there are a lot of them. I want to just talk briefly about some diagnostic studies, briefly about surgery, which cases would require surgery, and then briefly go over goals and steps of surgery, and prevention statistics. And first of all, what is it? So it's a neural tube defect. There are a lot of neural tube defects. This is one of the more common ones that we see. So I can't get the pointer on the screen. However, is there a way to, there we go, sorry. So this is a very, very simplified picture, it never looks just like this. This is way too clean. It's never this nice. So we have this is the vertebral body, spinal canal, spinal cord, which let's just say this is T12, L1, or just for argument's sake, then the cord should end somewhere around here, the conus, and the nerves would hang down. In this case, most of the time, these are mid or low lumbar, and so in this case, let's just say this is L4, L5, S1. There's a defect here. The cord should have ended way up here. The conus should be way up here, but the cord comes all the way down, out through the defect, into the dark is the spinal fluid. The sac would be lined by meninges, plus or minus skin. Usually if there's nerves in it, usually there's no skin. That's an open defect, or aperta, spina bifida aperta. And it's usually there's a big tangle. There can be lipomatous tissue in here, in which case it's all tangled up together. Very difficult to resect. So that's just basic schematic to show the different components. And you can see the nerves going all the way to the surface. So it's a spinal dysraphism we talk about, so it's a separation where there's incomplete closure or incomplete formation of the posterior elements of the spine. So that can be as minor as the spinous process didn't totally come together. So there could be a little gap, and that's occult spina bifida or spina bifida occulta, or one of the forms of closed. So now it can go all the way to this, where there's neural involvement. It could just be meningeal with the CSF. It could be nerve. It could be lipomatous. It affects in order of frequency. It's lumbar, sacral, followed by thoracic, followed by cervical. And this is just for spine, and we'll go over other entities. So CNS embryology, very briefly. So we start with the primitive streak, and that marks the formation of what's going to be head, what's going to be distal, sacral, and so on. And then right, left, and then that forms into the groove, goes into develop into the groove, and then that's anterior, posterior, and then we have gastrulation. So the blastula, which is just the single layer of cells, turns into the gastrula, which then is this multidimensional structure that has the following: the ectoderm, which is basically nervous system, and mesoderm, endoderm. And there are many more tissues that form out of each tissue type. These are just listed a few, just to kind of help categorize it. And this notochord here is important because this will stimulate the formation of the nervous system. So nice, another little schematic. So we have the neural plate. So notochord is down here, mesoderm. This is ectoderm. This is inner neural plate. The dark blue is the outer neural plate. And in between is the crest. So we have the notochord stimulating the neural plate to turn into a tube. This is primary neurulation, happens at 3 and 4 weeks. And so many problems can happen with that. So if there's incomplete closure of the tube, if there's early separation from the two types of ectoderm, if there's late separation. So in secondary, so once the tube closed, secondary neurulation then is forming the distal part of the spinal system. So basically lower lumbar sacral components. Another way to look at that, so this is what happens to the primary neurulation, where you have, like, if this is going to end up being the head up here, this is coming down thoracic, lumbar, and then secondary neurulation, there's a separate caudal cell mass, and then that'll take care of the rest of the formation. I'm trying to depict the neuropores. There's the cranial and caudal, neuropores, and this is all in primary neurulation. As soon as these close, then secondary neurulation starts, and that's the formation of the distal part of the spine. So if you have a problem with the closure of the cranial neuropore, then that can result in problems with the head and the brain. If you have a problem with the caudal neuropore, that's going to be spina bifida. And there's everything in between as well. So basically primary neurulation defects would be open myelomeningocele. Now that can also be said meningomyelocele, and they're both right. They're pretty interchangeable, so there's not one correct way. So we could also see a closed defect called lipomyelomeningocele, and that's a primary neurulation problem, and that's when the fatty tissue gets into, before the tube closes, the neural tube closes, fatty tissue mesoderm gets in there, and that turns into adipose fatty tissue, keeps it from closing. And then dermal sinus tract, which is generally a much clinically less problematic, but still can be problematic issue. And so secondary defects could be as benign as spina bifida occulta, where you don't know, you go your whole life, you don't even know you have it. In some cases, where it's just a little defect to the bone in the back. It could be a tethered cord. It could be a meningocele where you see something like this in the back, but it's skin covered. And it could also be caudal agenesis, where like sacral agenesis or dysplastic sacrum, where you just have maybe partial sacrum and then it just ends or is just very deformed. In chart form, then you kind of overview to kind of review it. So if we have a cranial or a rostral defect, the worst open, the worst would be anencephaly. If it's a closed defect, more likely closed meningocele or encephalocele, where you also have the brain elements in the meningocele. If it's caudal, most common spina that we deal with clinically, spina bifida aperta, and if it's closed, it could be a variety of things. So, like we already talked about. So the called the closed meningocele, myelomeningocele, or it could be a spinal lipoma without the neural elements pushed out. So now just to go over those types with pictures. So that was just kind of the brief categorization. So this is the closed with, you see a tiny, tiny little defect here in the posterior elements. And in this kind of case, there's most likely not going to be any other issues, any other problems. This could either be a closed meningocele or a closed more likely lipomyelomeningocele or just our spinal lipoma that then tracked up. And open defects. So this is the neural plaque code, and it's usually in this area, but they can also be upper cervical. So occult, again, here we have that little opening here. This is an axial CT where you see the spinous process did not come together, but likely then no other findings. Sometimes what can tip us off to that there might be something, a spinal defect underneath, could be a patch of hair, hypertrichosis, a dimple. There's so many different types of dimples, and there are some that are just very, very benign looking. So if they're low, so sacrococcygeal, midline, and they're either shallow or even if they're deep, if you can see skin deep to it, and for example, it's on the coccyx, those are dimples that are most likely completely benign, not related to anything that we need to worry about and image and work up. But then you look at the whole picture. You look at the buttocks. Are they symmetric? Is there good bulk and tone? Symmetric, leg function. That can be a sign as well of an underlying problem. So as far as dimples, if they're higher up, they're deeper, they're asymmetric. And the fold, the intergluteal fold is very asymmetric. Those are all things that I'm going to want to then look a little deeper in image. So now we can have other signs, capillary hemangioma, a little subcutaneous fat pad, a lipoma, that might tip me off to image, or also a caudal appendage. So all those things may tip you off. So now if it's a true occulta like this, where it's just a little spiny defect, there's rarely a tethered cord associated with it. The patient's function is normal. And I saw so many different sources state different statistics on it. What I've typically seen is 2 to 3% of the population has it, but I found this one also that I wanted to put that in. The National Institute of Neurologic Disorders reported up to 10 to 20% of people may have this. And what I typically see is probably, personally in my practice, maybe about 5% of the pictures I look at, I see this, anecdotally. So closed neural tube defects, these are some of the things that we would see. This is hypertrichosis. This is just the discoloration of the skin, the little capillary hemangioma with some little, an obvious defect of the skin with some little protuberances, and then this bulge, which could be fatty tissue. We can see sinus tracts, which that right there could be leading to a tract. This is a great picture of a caudal appendage. And this is potentially lipomatous tissue under here, or that could be a closed a closed meningocele, or it could have fatty tissue. But obvious defects though, where we want to image further. So this is a great little picture of this little thing right here is the sinus tract. And I couldn't get the track all on one image just because of the angle it was in. So that little dark line goes down to here, to that, it enters here, and then it tracked up into the canal, and there was all these cystic areas here, multiple cystic epidural and then intradural cystic lesions. And so with this, we just resected that sinus tract, and then went in and followed these cysts and fenestrated, closed the dura. And then before that, obviously, we found the phylum and just resected that. So just cut the phylum to decrease the tether. So here's a closed meningocele where it's low lumbar, upper sacral, where we most commonly see it. There's a cystic protrusion, it's skin covered. And in the closed ones, in closed cases like this, there may or may not be a tethered cord. It could just be a defect with cystic, so it's CSF, with the meninges herniating out, skin covered. And often the function of the patient is normal. So with a lipo, this could be a lipomyelomeningocele, a lipomeningocele, or because so plus or minus the neural elements, which is the myelo part of it, and it could just be a spinal lipoma. Like in this case, this depicts that the neural elements are staying deep down where in the canal where they're supposed to with the lipoma. And again, this is very clean. It's never this clean. It's always a tangle of tissue together. And this is showing some herniation out, and this is showing much more a bigger defect, more deformed. With just irregular tissue and lipomatous tissue. So I went over this a little already. So the premature disjunction of the two types of ectoderm cause so the superficial ectoderm splits away from the deep ectoderm before the tube closes. And that lets in the other tissue, the mesoderm tissue, which then turns into adipose, which then forms the lipoma and keeps. This is the bone, keeps this from closing. And the function can be normal in these folks, or near normal. So this is a great picture of lipoma, and it comes right out of defect here. Here's a picture of this little this little light marker is just a marker. It's not part of the defect. And it's just for imaging purposes. And so we could see where on the image where we're seeing the defect on the skin. And this little dark line is the sinus tract. On this picture, we see that this little white dot deep, that's actually a lipoma. We see there's a lot going on in this little picture. The cord is very low. So we have a tethered cord, we have a lipoma, and here we see the sinus tract. So now reviewing some aspects of open. So we have an exposed placode. Then there's no skin over that part, there's arachnoid, and then as you go more lateral, there's very thin skin, and then it transitions into the normal skin. So here we see that very simplified depiction of it, where you have the defect, this is the meninges, spinal fluid, and this can be an open defect without skin over it, or it can be a closed with skin if it's a meningocele. Usually the myelos are generally open. So this is a picture of, and this is a T2, so the CSF is the lighter tissue, the white. So this is extending all the way to the surface. This is the picture, this is the same patient where the neural elements actually didn't protrude out. It was just the the spinal fluid and the meninges. And in this case, it was still a low-lying cord, so it's still tethered, but the neural elements didn't protrude through. But you can see, I like this picture because you can see that the cord never closed. It never wrapped around, making the central canal in the cord. It just stayed open. And with a PERTA, you could also have you obviously have an open lesion, but you can also have hypertrichosis and capillary hemangiomas, and there's always a tethered cord with these. The patient's function is typically abnormal below the level of the lesion, but sometimes we do see functional nerve roots make it through and go on, so distal. Okay, so there's many clinical considerations with spina bifida. So we can see motor weakness, various paresthesias below the level of the defect, neurogenic bowel, neurogenic bladder, frequent UTIs, constipation. We can see psychological effects from it, such as depression. We see obesity. In general, we can see cognitive limitations in up to maybe about 20%. And we presume a latex allergy, and there's various theories for this. So if I categorize it by age group, the things to look for in the infant would be just gross motor function and atrophy. We can assess reflexes as well. As they get older, we assess for walking. Are they delayed in walking? What does their gait look like? When they get a little bit older as kids, then we can better assess bowel and bladder function. The same things we assessed before, but then we can start to get more detailed. And in adults, then basic symptoms, including pain and spasticity. We start to see spasticity, hyperplexia, and some. So other anomalies, so CNS anomalies, we see Chiari2 in 100% of open cases. And we see syringohydromyelia, which is syrinx, very frequently, diastematomyelia, which is a split cord, occasionally. I haven't seen it as much as this, but they were just some of the stats I found. And callosal dysgenesis, which is very common. So to just show you some examples of this, so we have, this is the occipital tissue, this is the cerebellar tissue, and so this is the torcula. This should be up here. So everything is just lower than it should be. And then the cerebellar tissue is tracking down here. This kid has a lot of other issues as well. We see some cysts here, we see a syrinx here. I'll show you more pictures on that in a second. We can see, with Chiari, we can see all of these things. So I'm not going to go through every single one, it would take all day, but I'll highlight a few things. We can see calvarial defects. This is a great picture of Leukenschädel, this lacunar skull. We can see that small posterior fossa I was just showing you with everything descended, low-lying cerebellar tissue. Go back to that picture, low-lying cerebellar tissue. Torcula is too low, which means the transverse sinuses are very low. So if we were go to a Chiari decompression, where we like to take off bone about 3 centimeters up, you would be exposing torcula, which you can do, but it's not going to do any good because it's not going to expand out. When you do that, you're trying to make more room for the cerebellar tonsils. So you're not going to get any benefit going higher than this. So you can still do it, take off some of the bone in the posterior spine, and a little bit of bone here, but it's not going to give you as much room with that low-lying torcula. We can just see a multitude of abnormalities. In some cases, these are very mild. Some kids, they're very, very severe. We can see hydrocephalus. This is a septal defect here. This patient also would have, we see colpocephaly. So this patient would also have dys or agenesis of the corpus callosum to allow for this enlargement of the posterior aspect of the ventricles back here. Okay, just a multitude of other things we see. For example, we see an irregular shape of the medulla, irregular shape of the midbrain. We can see just irregular shape of the cerebellum low, and it looks different as it's coming around the brainstem. It can have an abnormal appearance as it's the incisura, the dura that separates the supra and infratentorial compartments. It can have this towering appearance through a wide tentorium. The callosal dysgenesis, we can have heterotopias, which are normal tissue in abnormal locations. And we can see, sometimes, not all the time, with most of these things, we can see these abnormal gyral formation. So all spina bifida aperta has a Chiari-2 malformation to some degree or another, but they may not have every single thing listed on here. And then spine, we can see the syrinx, diastematomyelia sometimes, and very frequently segmentation anomalies of the spinal segments. So here's a picture of a syrinx, this white. So this is the cord, and that white is the CSF in the middle of the cord, right through here. So that should be about a millimeter or less usually. That spinal canal that's running through the cord. So other associated anomalies elsewhere, we can see craniofacial issues, multiple skeletal issues. Very frequently, we see scoliosis in club feet, and kyphoscoliosis very frequently. We almost always have some degree of GI issues, not always severe. Pulmonary issues, cardiovascular issues. We almost always have some degree of genitourinary issue. So here's a great picture of scoliosis in a spina bifida patient, and she had a correction by one of our spinal orthopods here that does deformity correction, and they did a beautiful job. This was just amazing. We have to be careful when we do these though, because we're taking, even after you've done a detethering surgery, so this child had an open case, it was closed at birth. There's always scar tissue and the potential for retethering to the point where you may need to redo detethering. And so now, and with growth, that can pull more on it. And then when you straighten, if you take an S and you straighten it, you're lengthening it. So you can create a tethering effect from that. So sometimes we would go in, and then depending on what we're doing, the extent of it, and what they've had in the past, sometimes we'll go in and we'll do a redo detethering before we do the lengthening, before the straightening. And now there's also, we're also starting to do procedures where we'll do basically spinal shortening, where we'll take out segments, and as we're straightening, to prevent that from happening. Some basic diagnostic studies that I've shown you a lot already, but as far as pictures, but one of the things, early on in pregnancy, we can look at maternal serum to check for alpha-fetoprotein, and we can look at amniotic fluid. So these will be positive in open defects only, for the amniocentesis, open defects only, not closed. And that just makes sense, because it's not exposed otherwise. Not totally accurate, but fairly, up to 70%. And if it's elevated, we repeat it. We look at an ultrasound. If the ultrasound is worrisome, we look at an MRI in utero. And this is a nice little picture showing a defect. And it's hard to say, well, impossible to say too much about the details of this defect, but there's an obvious defect. Sometimes on the imaging in utero, they look open and then they're one closed, and vice versa. So it's hard to say for sure. This is showing, at first you may not see what's going on here, but if you look at the pedicles, this is a clear dysraphism. So you have the pedicles here, and as you come down, this this pedicle is under that pedicle, and so on. It gets a little wider here, and it gets a little wider, and you start to lose the detail here, and here you really can't even see it. So this is the posterior elements. As you go down, they're splayed open like this. And this is that same patient here. You start to see a difference as you go down. This picture, you see the spinous process here, no process here, there's a defect, and then here you see a process. So this was one segment had a dysraphism. And this is just another great picture of the scoliosis we see with it. So we can look at in utero ultrasounds and MRIs, and obviously after birth, an MRI is very helpful to look to see the details of the lesion, as far as we image the whole neuroaxis, because we want to see what else is going on. What's the extent of the Chiari? And is there a split cord? Is there a syrinx that we need to follow? Is there anything else we need to deal with? As the child gets older, look at urodynamics. Briefly with surgery, here's a neural plaque code. This is what we call a transitional zone, where we start to see some thin skin. And so some of this, so we have to separate this, so when we close it, there's no skin in the closure, and then there's usually a little rim here, which is not viable. And then as we separate it, some of this, which looks very thin and maybe wouldn't be viable, starts to look viable during the procedure, and we can actually use it. So now this is a pretty average looking open defect from what we see. And when they get much wider than this, we have to think about, how are we going to close this? Do we need to do a relaxing incision here on the side? Do we need to do maybe like an S incision and then flap some tissue into it? Do we need to do a graft from the thigh? There's so many different considerations, so many options you could do. So we often involve plastics with the bigger lesions to help us with that. So if it's an open defect, we want to close it within about 48 hours, and this reduces the risk of infection. If it's a closed defect, it buys us a little time, because then we don't have spinal fluid leaking out, we don't have that same risk of infection. We can let the child get a little bigger, and they're not going to grow lengthwise, so I'm not worried about a tethering early on, causing a permanent neurologic issue more than they may have early on. And not all closed lesions obviously need to be fixed. It's the ones that, if we have an obvious deformity, a big lipoma, the obvious meningocele. So the goal is to reduce risk of infection, debulk the mass, if there's a lipoma, and release the tether. We cover the neural elements. Sometimes we do a muscle flap as well. And this is an area where there's really, so you have bone and nerves exposed. So when you talk about covering lesion, there's no tissue there to cover it. So you have to recruit surrounding tissue in to cover it. So there's always a defect with time, because you're moving things around, and you're not going to have normal. It's never going to look normal, but we can usually do a pretty nice job with covering it with layers to protect it. And with time, it looks usually sometimes pretty normal, sometimes not. Depends what the defect is, how big it is, and where it is. So basically steps. Actually, I just ran through that. So let me go through that again, because there was a couple of things I missed. So separate the neural tissue from the surrounding tissue. We actually, if we can take that neural plaque code, if we can roll it in on itself, we'll do that. And with just in suture PIA, which is it's thinner than tissue paper. And then if a lipoma is present, debulk that as much as we can. Find the phylum, section that. And then we separate the dura, then is also not over it. It's all just splayed out. So we find where the dural edge is, see if we can roll that in and close it. And if that is too tight, if it's not reaching, if we feel like that's going to pinch or tether, or create a tether, we sew in usually a bovine pericardial graft to make more room for that. for the underlying neural elements and covered with muscle, fascia, skin, plus or minus a flap. So prevention, in a nutshell, folic acid, also as far as vitamins B12 can help. And in a study I found that they looked at thousands of patients. There's fairly low rate of spina bifida, but from 6 out of 2,000 went to 0 just with treating with folic acid. And I thought this was interesting. I had to put this in. 30 plus years ago, the cost per lifetime per person was about $350,000, and I had to laugh at that because today that would be one hospitalization. So, and I couldn't find what the current cost is. So incidents, I saw everything between, and if you look at the last 30 years, you'll see everything from 1 in 1,000 to 1 in 3,000. And then are we looking at the US, or are we looking globally? It's somewhere between 1,500, 1 in 3,000. The most common I've seen is about 1 in 2,500 in the US. And so things that can increase your chances, excuse me, of having spina bifida are prior pregnancy with it, partner that has it, obesity, pre-pregnancy obesity, diabetes type 1, epilepsy treated with various medications that may have a higher chance of causing it, so valproic acid and carbamazepine. And there's a lot of other medications that can be linked to it. Those are just 2 of the most common. And also close relative. So it's not just folic acid and B12. There's genetic factors, and we think environmental factors because there's different locations geographically where we see a higher rate. All right, quiz time. What's our time? Time-wise, we have a couple minutes.
Yeah.
Okay. So, which entities are categorized as spina bifida? I'm not sure how to quiz here because everybody's remote. You can quiz yourself. I'll give you another minute here. Quiz yourself.
A, B, C,
All but H.
Not H.
All except H.
Yeah, we'll go with all but H.
Which one? All right. So which ones are not spina bifida on this list?
H.
H,
H is not.
F's not spinal, but,
F is not.
okay.
D,
D is not. Exactly. Right. So D and F are neural tube defects. They're not spina bifida. And H, obviously. All right, is that somebody asking a question?
They were saying H.
Oh, okay. All right. Okay. Which conditions are associated with spina bifida?
E,
Let me ask this the other way, the easier way for this format. Which are not?
All except D.
You don't remember what you said, GI stuff.
Right. Okay, that was an easy one. Any questions?
I do have a question. How often you see a developmental dysplasia of hip with these patients? The developmental dysplasia of
Okay, hip dysplasia? An actual statistic, I'm not sure. We absolutely see it. I don't, it's not in every patient I see with spina bifida. I don't know a number offhand.
But it's increased incidence to it.
I'm sorry?
Does it seem like an increased incidence? Is there, I guess, association that way?
Definitely, yes.
Is there a specific age where you do the tethered cord release?
So, yes, if it's open, it's right away. If it's closed, it depends on what is associated with it. So is it a closed lesion where it's still quite obvious and deforming, and is the cord very low? Yeah, I'll probably do it at a few months. Is it very mild where it's maybe just a tethered cord and it's maybe just one or two segments? Well, maybe there's a range of what's normal for the conus. So if it's kind of lower normal, L2-3 at birth, just watch it. Let's just say it's at L4-5 at birth. I would do it sooner. Is there a right answer? You have to do it at a week, a month, 6 months? No. It depends. If it's, let's just say it's straight up just a tethered cord, nothing else, and it's at 2-3, we may never do that. We may just watch them, you maybe image them in a year, and now it's at L2 because it rises with time, and then it's not tethered. And they're not having any symptoms with that, let's say, then never. Versus it's like at L4. I would do it. I would recommend doing it. I would probably wait several months, even a year. I would want to do it before they start having growth spurts, which you could argue once a year. There's no right answer for that.
Can I ask, are syrinx formations common or part of these defects?
Very, very common.
Inherent or primary or secondary?
Probably, I would say secondary to it because of the tethering. That being said, you can see a syrinx in an otherwise totally normal person without a tether. That's why I'm kind of struggling on that one, because it's.
And with those, let me say they're different level than the defect.
Right.
Are there associated impairments at those levels?
Often, no. Now, if it's a progressively enlarging syrinx, then yes. Most of the time they're not, yeah.
They can have dissociative anesthesia, what we call as a temperature and light touch defects without much of other. If it is enlarging and causing compression of the.
If it's enlarging, absolutely give symptoms at that level, absolutely. And now, that's another avenue off of this, but if we do have an enlarging syrinx with or without a relation to spina bifida, then we can treat it with so many different avenues off of this. So let's just consider the syrinx alone, not any other entity, that treating that might decrease it. So if it's a syrinx alone and it's enlarging, we can do a procedure where we put a little shunt into the syrinx. It's like a little T-tube. It's like a little ear tube. We put it in the syrinx, so open the between the dorsal columns into the syrinx, and then close up. It's a little tricky to get it to stay, but there's little dentate ligaments where we can manage to secure it so it doesn't slip out and it continues to drain the fluid from the syrinx into the subarachnoid space. Now, sometimes doing a PRA decompression, will decrease the syrinx. Sometimes shunting will decrease the syrinx. So a lot of these patients need a shunt, not all of them, and a fair amount will go on to need a PRA decompression, but not all of them. Any other questions?
Well, we've got a couple minutes, so I'm going to ask a very unstimulating, sort of cerebrally unstimulating question. Being a general pediatrician, one of the bane of my existence of the years is what do you do with the sacral pit? You got a low-lying pit, you got the newborn, you got a pit. Clearly if there's something draining, if you can't see any bottoms, you get a little more excited. Over the years, I've had people react different ways.
Yeah.
When do you want me to do it?
If it is it's a single midline, skin-lined sacrococcygeal dimple, nothing.
That's what I've done. That's what I've done over the years.
Yeah.
So,
It's just a little bit of fibrous tissue attached to the bone. Chances are super small that it's anything other than that. And then, but then also, you just watch with time, are there any other signs? If there's anything, it lowers your threshold for getting imaging. If there's anything, right? But if there's just that, I have a very, very low suspicion. But if I see anything else, then I'll go to, like, let's say there's a unilateral lower extremity size difference, atrophy, function difference. When they're not potty training when they should, and it's really delayed, or they're not walking and now they're 15 months old and there's an issue, then that would lower my threshold for getting imaging if they have anything. They could have a fat pad, a little hypertrichosis, and it could be there's degrees of that. It could be very, very mild. But it depends what you see and how that would then, the more you see, the more worries you're gonna get. But if it's just, everything else is stone cold normal, and it's midline, skin line, low, and that's the only thing, those are the ones I don't worry about. Everything else, I have a heightened level of concern, and then I kind of look at the big picture, but it's not gonna hurt to get an ultrasound in a baby if there's that concern. But those are the ones I don't. Those are pretty much the only ones I don't. And everything else, I'll at least look at an ultrasound. I don't want to get an MRI, I don't want to jump and get it, because you need full sedation. And if you have a negative ultrasound, you don't need that.
I have a patient, 7-year-old.
If folks online are not asking questions, please mute. We're getting a little echo in here.
So 7-year-old patient was basically came for a normal well encounter, but had some difficulty, was told to have autism spectrum disorder, but had difficulty of walking since when she was like 2-year-old. And at that time they did see a spinal dimple and was told to have like, they could see the floor of the, the skin was intact. So nothing was done for that. Now she's 7-year-old, she cannot walk. She looks like she has girdle defect. She has bilateral flexor weakness on both sides. She cannot stand on both, single leg. She is not toilet trained yet. She does have cognitive defects, cognitive intellectual disability. So she also had DDH at one point, which has never been treated. So that's why I asked that question. So, and then on my exam yesterday, a few days ago, she does have a spinal dimple, which is very low.
Has she ever had a spinal MRI?
No.
Oh, she needs one.
She has not gotten one.
Yeah.
So I had this difficulty in assessing whether it's a tethered cord or if it's her DDH. So I made her walk up and down, which I could not figure out.
Okay.
So she might come to you.
No, definitely. I would, and it may be negative, but you've got a lot going on, and how do you, I would want to prove that that's negative, that we don't need to do anything.
Yeah.
That it's not also a tethered cord, or could be a spinal lipoma, you don't know, or split cord.
Yeah, I was like, whether it's a DDH causing her have to have walking problem.
Right, it could be.
Yeah.
But, yeah, and there is an association, so.
That's why I asked that question.
So many things that could be, or it could be nothing. Yeah. Right.
It's DDH. It's developmental hip dysplasia.
Anything online,
Horses well
Megan?
out of the barn.
Yeah.
Unfortunately.
Thank you.
That may be all right.
Thanks.
All right, thanks.